Welcome to one other session of Pulmonology Read Aloud. My name is Dr. Anshum Aneja Arora. I am a practicing pulmonologist, and today I will be talking about severe asthma and the role of biologics in the most simplified manner. The term severe asthma has changed considerably in the past with terms like severe uncontrolled asthma, refractory asthma, and poorly controlled difficult asthma, complicating its definitions in the past. However, severe asthma is just a subset of asthmatics who are not controlled. So, if you deal with a population of uncontrolled asthmatics who require a higher intensity treatment, around three-fourths of these patients will continue to have poor symptom control despite optimizing their treatment, and these will require further optimization and modification of other factors. Now, amongst these, a minority or subgroup of patients will still continue to have poor symptom control despite doing everything to the dot. And this is the group of patients who are called severe asthmatics. So, how do we approach these patients of severe asthma and what does it mean clinically for us? To precisely understand the definition of severe asthma, it's important to first understand what an uncontrolled asthmatic is. An uncontrolled asthmatic is a patient who continues to have daytime, nighttime symptoms or requires frequent medication change or recurrent exacerbations and increased reliever use, as in this GINA guideline assessment table. So, if a patient meets any three or four of these symptoms, we can characterize him as uncontrolled asthma. And once we've done that, we can further differentiate this patient into difficult to treat asthma group. Now, what is different in difficult to treat asthma group? So, now this patient is already given medium or high dose ICS to control his symptoms. Sometimes even controllers and maintenance oral steroids may be given. But despite giving them a good treatment, a high treatment, patients become uncontrolled. So once you try to step them down, it is difficult, and these patients also relapse. So this patient group is the one which comes into the difficult to treat asthma group. The good thing is that most commonly this occurs due to treatable modifiable factors, and so this patient group is manageable. Now, coming finally to the severe asthmatic group. So, severe asthmatic is that patient who is uncontrolled despite doing everything, despite correcting his inhaler technique, optimizing his therapy, giving him high doses medication, correcting all the contributory factors, and also making sure that your patient is adherent. However, this term severe asthma is a retrospective label. You cannot label a person as severe asthmatic the first time he comes to you unless you have ensured that all the modifiable and contributory risk factors have been addressed. So, if your patient improves just by a correction of an inhaler technique, he is probably a difficult to treat asthma and not a severe asthma. And once you classify him as severe asthma, then you can add on therapies. Then you can address his innate mechanisms and you can consider biologics also. So if you look at this GINA guideline statement 2022, we all know that there are two tracks that have been suggested, of which track 1 is the preferred track, which says that we have to start all asthmatics with low dose ICS formoterol instead of SABA relievers, and we go up the steps as and when the patient needs, and we go to lower, medium and higher dose ICS, and at step 5 we can add LAMAs, or this is the step of patients who are not getting controlled, and here we need to assess them in a severe asthma clinic and assess for phenotypes. So step 5 patient is the one that becomes the patient under concern. And when you treat this patient, the first thing important is to confirm the diagnosis and reconfirm the diagnosis. Number 2, we have to look for factors that are causing the exacerbations, factors that are causing symptoms. Number 3, we have to review and optimize his management and make sure he's on the right doses. Next, we have to assess him again, first at 3 months, then at 6 months, and make sure that he is
adherent to the treatment and he's responding to the treatment. Step 5, we have to, if we think that this patient has severe asthma, we have to assess him for the phenotype of the severe asthma and investigate him accordingly further. And then, in case he does not follow in the group that requires T2 inflammation modulation or directed therapy, then we have to consider other non pharmacological treatments for this patient. And once we've established the final treatment, we have to continue the collaborative optimization with the patient, and this is how we'll be able to assess our patient. Now look at this flow chart again from GINA guidelines. There's a beautiful flow chart for severe asthma given in their section on severe asthma. You must go through this chart, and I'll be just breaking this chart down and talking about it in a bit of a detail. So the first and the second steps we all know now. Reconfirm the diagnosis and look for comorbid factors. Is he a smoker? Is he having an environmental exposure? Is the patient having an occupational exposure? Is he an obese asthmatic? Is it the rhinosinusitis or polyps causing the problem? And mind you, it's a practical tip that most asthmatics will have some form of nasal allergy. So look out for those signs and look out for sinusitis. I personally check each of my asthmatic for nasal allergy, and most of the time the cause of uncontrolled asthma may lie there itself. So once you've done that, then you go to step 3. So step 3 is basically to optimize his management. Make sure he has an asthma education plan. Make sure you're giving him the right dose of the steroid. You're giving him the right inhaler which the patient understands. You've done all non-pharmacological interventions, smoking cessation, weight loss, and we have treated the comorbidities and factors. Once through with that, we are assessed our patients and reassessed and followed them up after 3 to 6 months. That is very important. At the time of assessment, we need to ask ourselves whether our patient has improved after modifying all these factors. Is our patient still uncontrolled or controlled? Now, if your patient is not uncontrolled now, then you may continue his management and step down if you were giving higher dose of steroids or giving oral steroids. But if your patient falls back into the same spectrum as soon as you discontinue his treatment or step him down, probably he's going into the severe asthma cascade. And if he's still uncontrolled, then definitely work him up for severe asthma and check for other variable risk factors. So, now to treat this patient as a severe asthmatic, it is important to differentiate his inflammatory type or his phenotype and endotype. So, what is it phenotype and endotype actually? A phenotype is an observable characteristic of a patient. Is he an obese patient? Is he a smoker asthmatic? Is he an adult asthmatic, a childhood asthmatic? Is he a good responder, poor responder? And what is the potential driver that drives the disease? That pathophysiological mechanism is his endotype. So, is eosinophilia involved? Is it non eosinophilic? Is it atopic, non atopic? So, once we know that and once we characterize that, we can actually target the mechanism behind his asthmatic. So, now most of the patients that we deal with, which come under the realm of the severe asthmatics, are the ones who have a T helper 2 high immune mechanism. So these are the patients in which the T helper 2 cells are in more of an overdrive. So the related markers, the interleukin 5, 13, and 4 are more in the airways. These patients are commonly more severe, more steroid responsive, eosinophilic, and also have the IgE component. In contrast, some of the patients, around 30% of the patients, may have a lower T helper 2 phenotype. So, again, they may have different mechanisms which may be working, and so they may be less severe, less steroid responsive, and they may not have the typical eosinophilia. These mostly are the obese asthmatics and the neutrophilic asthmatics. Now let's have a look at this inflammatory pathway involved in asthma to understand the endotype of an asthmatic. Now, inflammatory pathways in asthma are majorly the eosinophilic pathways and the non-eosinophilic pathways.
Now, when the allergen is introduced into the cell by means of an antigen presenting cell or a dendritic cell, it stimulates the thymic stromal lymphopoietin to produce naive T cells. When these naive T cells undergo differentiation into Th2 cells, the mediators released will direct the response. So, if it's IL-13 or interleukin 5 release, it can stimulate the eosinophilic response, while interleukin 4 and interleukin 13 together can stimulate the B cells to produce IgE, which will further, by the role of mast cells and histamine release, produce the inflammatory reaction. In the non-allergic eosinophilic asthma form, the allergen may not be involved. So it could be the direct introduction of other molecules, pollutants, and other organisms. So now when the macrophages are stimulated and the NKT cells are produced, or the thymic stromal lymphopoietin is stimulated, then another set of mediators is produced, which may be IL-33 or IL-25. So these different mediators can again stimulate the muscles, the smooth muscles, cause its contraction without allergic pathway being followed. And in the neutrophilic asthma pathway or the postgranulocytic pathway, the differentiation into naive T cells goes on with Th17 cell rather than Th2 high predominant cascade, and this is how other mediators and neutrophils cause the inflammatory reaction. So, when we are dealing with asthma, if we are able to identify which of these pathways is being followed, which of the following cascade is going through, then we can target our therapy to that. And most of the therapy that we have now has target towards the Th2 high airway inflammation. So once you investigate your patient, you need to find out which kind of inflammation the patient has, and all the investigations will be directed towards it. Say Ig levels, the skin allergy test, the fungal precipitants test, making sure that the eosinophilia is there or not there, if a patient is on steroids, interrupting and stopping steroids, and then checking and rechecking this eosinophilic profile. And once you know that your patient could have a Th2 airway inflammation, a T2 high airway inflammation by means of biomarkers, then you may proceed and then you may choose a biomarker for this patient for customized precision medicine. So the biomarkers are those attributes that can help us decide which type of inflammation this patient has. And in your patient, then you can go ahead and find them. Now there are four most common biomarkers that serve well in severe asthma clinically, and amongst these, three are easily available. Now these are total IgE level, blood eosinophil levels, sputum eosinophil levels, and FeNO measurements. So while sputum eosinophil measurements are not very commonly available, IgE, blood eosinophil, and FeNO can be used. So IgE levels more than 150, blood eosinophil definitely more than 300. There are various cutoffs in various statements, but 300 is a good cutoff, and FeNO measurements over 15 adults. These are easily used to help us identify the allergic asthma phenotype or the eosinophilic phenotype or the inflammatory phenotype. And this also predicts that there will be a good response to IL-5 targeting therapies or IgE targeting therapies or IL-4 targeting therapies. And so these biomarkers are what we should be doing in all our patients whom we have classified as severe asthma. So if you look at the flow chart, once your patient has been identified to have this T2 high airway inflammation, we would consider increasing the steroids, because again he's eosinophilic, he has T2 high inflammation. So remember, what is the first thing? He will be more steroid responsive. Are we just lacking on that front? Are we considering that as well? And once you've modified all things according to the information you received, then you can consider add on non-biological treatments also for this patient before embarking on the journey of biologics. Because once you decide on giving this patient biologic or type 2 targeted biologic therapy, we have to ensure that patient will be able to bear the cost, be regular with the routine and the regimen once we've instituted that. So that whole checklist has to be sorted up before you take up any patient. But you will notice that in certain patients, there will not be this T2 airway inflammatory component. These patients will have a non eosinophilic component. The Ig also may not be high. And in case you have no evidence of the T2 airway inflammation, then guidelines suggest that you should first go back and review the differentials again. You check your basics, the inhalers, adherence again, and once you've done all that, now investigate for other problems. Do an HRCT, check for TB infection, check for MAC infection, maybe do a bronchoscopy. Ensure that you've given a good LAMA to the patient, maybe a low dose macrolide. And if nothing works, then patients can also be referred for bronchial thermoplasty, and that may have an add-on role in this group. Now, what about the patients who already fulfill the eligibility criteria? Then we have three main biologics available in India. One is omalizumab, which is anti-IgE, anti-IL-5, benralizumab, anti-IL-5 receptor, so mepolizumab, anti-IL-5 and anti-IL-5 receptor benralizumab. There's also globally availability of anti-IL-4, dupilumab, and anti-TSLP is now the next kid on the block, tezepelumab. So once we remember our cascade and inflammatory cascade, you would remember that anti-Ig omalizumab works well for patients who have the Ig predominant cascade. These patients will usually have atopy, they'll have sensitization on skin prick testing, the IgEs will be positive. Benralizumab and mepolizumab work well for patients with eosinophilia because they act at eosinophil production level. So these patients will have more exacerbations in adult onset asthma, polyposis, and mepolizumab also in case of HES or eosinophilias of other kinds, you may have a good role. In case of dupilumab, again, high blood eosinophils and pheno, but it also works in children and is one of the biologic that is recommended even in children more than 12. Now, amongst these biologics, since tezepelumab is still not in the market, it's more investigational. We're still looking at the pathways where it may be working and helping because it has a very broad coverage. But amongst the specifics, omalizumab is very well studied in children above the age of 6 years, mepolizumab above 12 years, benralizumab about 12 years, and dupilumab has even been used in younger children, and they all work for the eosinophilic diseases, and mepolizumab especially has been proven to work well in EGPA, in hypereosinophilic syndromes, patients with a lot of nasal polyposis, and even atopic dermatitis. So that's the way you can distinguish and decide which one you need best. And amongst the doses, omalizumab is given in a 2 or 4 weekly dose. Mepolizumab is once a month. Benralizumab, the first 3 doses are monthly, and then it will be 2 monthly. And dupilumab is given as loading dose followed by an alternate weekly dose. Amongst which most all of them are subcutaneous except reslizumab, which is given in the IV infusion form. And benralizumab is an additional benefit. It comes as pre-filled syringes. So the patient, it's very easy to administer, self-administer at home. Once we know that the patient is safe, he can take it easily. And mepolizumab may require reconstitution. One problem with omalizumab that we've seen is that the weight dependent dosage really precludes its use. We may need a higher dose, it may be more expensive for the patient, and there are more chances of anaphylaxis and severe reactions with omalizumab as compared to the other biologics that are available. So depending on which mechanism are we suspecting and where we want to target, the available biologic therapy can be used for targeted treatment, and more and more patients are being offered this therapy as an add-on treatment at the end of the severe asthma cascade where patients are not responding to our usual treatment. So once we decide what our patient characteristic needs, we can choose one of the biologic and at least a trial of 4 months should be given for a patient before we assess the response again. We decide whether his asthma is improving. If it's improving from 4 months, you can try it for 6 months, extend it for up to 12 months. If it's a good response, you can continue it. If you do not see a good response in 4 months trial, you may consider stopping it, switching it, adding it on. But whatever course it takes, remember to keep evaluating the patient every 3 to 6 months and try and decrease the oral steroids for this patient, try and decrease the other therapy. If your patient does not respond well to biologics, maybe again we are dealing with another type of inflammatory pathway. Go back to the basics and see if there is a response to non T2 high targeted therapy and optimize the patient. So clinical goals will vary from patient to patient, but minimum 4 months treatment has to be given, and you have to see the criteria of the response. You can check his symptom scores, the lung functions, exacerbation rate, the quality of life should improve, and improvement in other factors. So red, yellow, and green light. Red light is a non-responder at 4 months, you discontinue. Intermediate responder, continue for a year and reassess. And green, you may continue further. So just to revise, if you look at blood eosinophil, the more the blood eosinophil anti-IL-5s work very well in non-atopic asthmas, the lesser the blood eosinophil, the T2 low asthma, bronchial thermoplasty, macrolides, and weight loss may work. If you have more Ig levels, omalizumab is the treatment of choice. But if you have good Ig and good eosinophil level, all anti-Th2 mAbs can be given. Let's conclude with this flowchart. You see a patient whose symptoms are due to asthma not getting controlled. You check for adherence inhalers, you check for other comorbidities, and you check whether he's a non-asthmatic. If you've met most of the dots, he is a severe asthmatic. Look at the pathway. Is he a high T2? Consider biologics. If he's non-high T2, consider LAMAs, pulmonary rehab, and then modify and collaborate again with the patient. So this is all from me from the severe asthma end. Thank you and happy reading.